Thanks for sticking with us to the end. I think we have an interesting panel lined up for you this afternoon on psychosocial influence on pain. My name is Jeff Mogil from Mogil University. I'll be speaking to you tomorrow morning, but I'm going to moderate this, which basically comes down to just introducing our three speakers. First up is Leonie Koban, who is a psychologist and neuroscientist. She earned her Ph.D. at the University of Geneva in Switzerland. And is currently a research associate at the University of Colorado at Boulder. And as you'll find out, she uses a number of different experimental methods to study social influences on pain and emotion, as well as the study of my personal favorite phenomenon of all time, the placebo effect. Dr. Koban will be talking about how other people's pain reports influences one's own experience and physiological responses to pain. And so with no further ado, Dr. Koban.
Thank you. Okay, can you hear me all right? Okay. So thanks for the introduction, and I'm happy to be here and talk about social influences on pain. So as you probably all know, pain is influenced by a lot of medical and physical factors, but in addition, there's also a lot of psychological and contextual factors that influence pain. And these are just a few examples. So they include distraction. For instance, when a doctor gives a flu shot to a young child, they often use some kind of distraction strategy to direct attention away from the pain. Then expectations can increase or also decrease pain, depending on the type of expectations, and they're important for placebo effects, for instance. Learning from prior experiences will also influence expectations and thereby pain. And emotion and anxiety can influence pain. So anxiety of pain can increase pain, but anxiety of something else or fear of something else can also be a distraction of pain, of course. And positive emotions, for instance, listening to pleasant music, will probably decrease the experience of pain. And what I'm going to focus on today is social and cultural factors. So there are again a variety of social and cultural factors, and I'll walk you through those. So presence and support. For instance, during a painful treatment, holding the hand of a partner or a loved one, a family member, can reduce the unpleasantness and also the anxiety of pain and thereby the pain itself. And this can also be even a healthcare provider if the relationship is supportive. And then, oops, this is not really working. So it's kind of, now it's only advancing here, but not on the projector. Sorry about that. I mean, otherwise we can just try to...
Yes.
Yeah, no? Okay. Well, okay, now it works there at least. Okay. So on the other hand, of course, if there's a presence of disliked people or maybe too many people, that might be also a social stressor and could increase pain. Further, there are cultural beliefs and about pain and healing, for instance, rituals or beliefs about the meaning of pain that can influence pain and also treatment outcomes. And then another important factor is the relationship between provider and patient. For instance, group membership, perceived similarity, and trustworthiness might influence pain and treatment outcomes. And then what I will focus on today is how other people's ratings, other people's behavior and social norms can influence pain and experience of treatment. So to give you an example, imagine you just are on a maybe conference trip to Alaska, and you meet some locals that try to convince you that it's actually really fun to run around outside in the snow in your swimsuit. And they tell you, oh, it's actually not that bad, it's really fun, it's not that cold, it's not that painful, just join us and jump into the whatever, there's probably no water to jump in. So would this influence your behavior? Would you join them in your swimsuit? And more interestingly, would this also change your perception? Would it be actually fun and not that bad? Or would you just kind of shiver through it and, yeah, to be not left out? So what I would like to convince you of today is that, yes, indeed, what other people tell us about pain, of course, cannot completely change their experience, but it can definitely modulate it. It can both reduce or increase pain and also physiological responses and brain responses to pain. So this is the illustration of a large social network at two different time points, in 1971 and 2000. And what you see here is that each of these nodes or dots is one person, and the links between them are relationships between these different people. So for instance, friends, family members, or co-workers. And the color of the nodes reflects whether they're a smoker in yellow or a non-smoker in green. And you already, on first sight, you can see that the proportion of smokers decreases over time from 71 to 2000. And then what the authors could show with advanced statistical methods was that the kind of likelihood to quit smoking was increased if one of your kind of social links or people close in your social networks had quit smoking before. So they could show that smoking or the decision to quit smoking spread like a kind of virus through these social networks, showing that decisions about health and health outcomes are influenced by social ties and relationships. And in psychology, the study of social influence and social conformity has started in the 1950s with the experiments of Solomon Asch, and you might be familiar with this. So the task was relatively simple. Participants just had to match the length of a reference line, seen here on the left, to the length of these comparison lines. So they had to say which one is the same length. And they could do that perfectly fine, 99% correct probably, when they would do that alone. But then when Asch had the participants perform the task with some other people, which the participants thought were other participants, but actually they were confederates of the experimenter, and they were instructed to give systematically the wrong answer in some of the trials. And what Asch could show was that if the participant here, all of these confederates had in a given trial given the wrong answer, the participant was quite likely to also give the wrong answer, even though the task was obviously very simple if they would do it alone. And conformity doesn't only appear in humans, we can also see it in monkeys. For instance, here in a study from 2013 that has shown that learned preferences about food will be transmitted to the younger generation, even though there's no direct kind of aversive experience in this young generation. They just kind of eat the food or the colored corn that their parents prefer. And then interestingly, when they migrate to a different colony, they adapt to a different food color. So kind of one of the long-lasting questions for this kind of research was whether these changes just reflect changes in overt behavior or in what people say or maybe what monkeys choose, or whether they also kind of reflect changes in experience and perception. And in the last decade or so, neuroimaging and in humans has also kind of started to weigh in on this question. For instance, in this study by Jamil Saki, they presented participants with faces and asked them to rate the attractiveness of these faces. And then after each phase, they gave them the ratings of their peers. And then in the second round, participants had to rate the attractiveness again. And what the authors could show was that when the peers had rated the faces as more attractive than the participants, they adjusted their ratings in the second round to a more positive rating. So they adjusted towards their peers. And the same was true when, or the opposite was actually true when the peers had rated the faces as less attractive. Then the attractiveness ratings of the participants would also drop. And interestingly, these changes in behavior were also reflected in changes in brain activity in areas related to reward and valuation processing, such as the nucleus accumbens and the basal ganglia and the orbitofrontal cortex. So this shows that it's not only behavior, but it's also really changes in brain areas that process the attractiveness or the value of these faces. So this has been shown for attractiveness of faces, also for music ratings, and there has been even shown effects on memories distortion. So people change sometimes their memories if other people kind of report memorizing something else. But what about pain? So there's actually quite a lot of intuition and also some initial evidence that how pain is experienced depends on social factors and social influences and the pain expressions of other people. For instance, one example is social referencing, which is especially important during development. And so, for instance, when a toddler falls or a young child falls from the bike, they often, or if they just encounter any new situation, they often first look at their caregiver or any adult in the room. Then, depending on what the kind of adult or the caregiver is, how they are reacting, this will influence the pain. So if the mother or the father is kind of like, oh my God, poor child, and like panics, the child will have a much higher expression of pain and start crying much more than when the parent stays relaxed and smiles and just stays calm. And also in adults, there's evidence that when participants, for instance, first observe another participant that seems very pain tolerant, they will express less pain and also show less physiological symptoms of anxiety than when they have first observed another participant that was very sensitive to pain and showed a lot of pain behavior. So we wanted to build up on these initial findings and also use physiology and brain imaging to look at social influences on pain. So how do we do this in the lab? We usually use a thermode, which is this little device here, which can heat up pretty quickly to the temperature that is comparable to a hot cup of coffee. So it's painful and uncomfortable, but we're not burning people. So the temperature starts usually at baseline. We put this on the forearm of the participants, and then it heats up for a few seconds, which is painful, and then it goes down again. And then after each such stimulation, we measure pain in different aspects. We ask participants how much pain they felt, which is the gold standard in clinical practice, obviously. So they rate the intensity on a scale from 0 to 100. And then to also get a more implicit measure of pain and distress, we measure physiological responses, especially skin conductance responses to the pain, which reflect autonomic arousal. And finally, we also look at brain responses to the pain using fMRI. So how do we manipulate the social information? So we, before people get this pain, we show them we tell them are the pain ratings of other people. So we kind of show them the same scale again that they use themselves for making the ratings. And then we tell them that each of these vertical lines reflects the pain rating of one previous participant. And in this example, most of these social ratings would be low. And in this example, most of these social ratings would be moderate to high. And in reality, these pain ratings are actually, or these lines are computer generated, so they're not predictive of the actual heat that people get. And this allows us to assess the effect of the kind of social ratings for high versus low on the pain. So in the first study, we measured behavior and physiology, and we see here a very strong and significant effect of the social information on the pain ratings. So when participants thought that other people had rated the pain as rather low, they had much less pain report than when they thought that other people had reported the pain as quite high. But of course, this is just behavior, so it might reflect just change in how people talk about pain, or some kind of just overt conformity without actual change. So we were quite curious to look also at the skin conductance responses, and actually quite happy and also somewhat surprised when we found that also the skin conductance responses to the pain were significantly modulated by the social information. So at time 0 they get the pain, and then this is the skin conductance response, and you see that in red the social high is significantly higher than the social low condition in blue. In the second study, we also used fMRI, and but we also, in addition, of course, we still measured behavior and physiology to replicate our findings. And again, we see a strong effect on behavior and also on skin conductance responses. And when we compare the brain activity to the social high compared to the social low trials, we see increased activity in a number of regions that are typically associated with pain processing, including the cingulate cortex, here the thalamus, and the insula. In addition, we also found increase in activity in prefrontal areas, and they're typically related to attentional and behavioral control, and these might potentially reflect the kind of increased expectations of pain during the social high condition. And so I didn't talk about another kind of manipulation that we had in the study, which involved kind of a learning manipulation of pain. And this allowed us to compare the brain mechanisms or the brain activity changes for social information compared to learning effects on pain. And interestingly, we found that the increased activity for the social information in purple was quite in different areas than the activity increases for the learning effects on pain, indicating that social influence effects are different in their brain mechanisms compared to the learning effects on pain. So as an interim summary, social information can alter pain behavior and also physiology and brain responses to pain. And they might do this by kind of changing expectations about pain. So another topic or kind of recent line of research that I would like to talk about is how social information can influence how we observe pain in others or empathy for others. And I think this also is quite relevant in a health care context when we diagnose people and when we kind of like assess the severity of pain in others or in patients. So how do we do this? We show people pictures of hands and feet that are about to be injured or that are cut or burned or, somehow cut again. And we then, before people see each of these pictures, they are again shown the ratings of other people, and they're told that these ratings are what other people think how much pain this person is in. And again, these ratings are computer generated, so they're not predictive of the actual or normative ratings of observed pain in these pictures. And what we found is that when participants see the low social ratings before these pictures, they rate the observed pain much lower than in the social high condition. And again, this change is also reflected in skin conductance responses. So they show higher physiological arousal to the social, to the pictures that were preceded by the social low ratings, the social high ratings compared to the social low ratings. So others' opinions can influence both how we experience our own pain and also how we perceive pain in other people. And there's some caveats. Of course, we do our research in the lab and mainly in undergraduate students. I mean, not only, but mainly. So it's an open question for future research whether these findings could be also tested in patients or, in the case of empathy, maybe also in healthcare providers. And then, of course, in real life, social information can also be actually helpful in determining the right amount of pain. So this is known as the wisdom of the crowd effect, where when we aggregate over many opinions, we often, or typically, come to a more accurate perception. So despite in the lab, here we kind of, because the ratings are not predictive, they kind of create some kind of bias. But in real life, social information might be actually also helpful in most cases. So to end with some potential implications or applications for clinical practice, I think it's important to keep in mind that patients' expectations might be influenced by what they hear from other people and also by cultural and norms and beliefs. And knowing about these expectations or asking people about these expectations might help to discuss them openly, and if they're very negative expectations, to somehow create or counteract more positive expectations. And then on the positive side, I think that social information can also be harnessed in order to reduce pain or to increase positive expectations. For instance, if a treatment is known to help a lot of people, it might be also good to kind of emphasize that and to kind of create positive treatment attitudes and expectations in patients and thereby improve treatment outcomes. And with this, I would like to end. I would like to thank my collaborators and you for your attention. Thank you. And I'm happy to take questions.
Yeah, so what we've decided to do is have burning questions related to each talk now, and then we're going to have a session with all of the panelists at the end. So does anyone have a very discrete question? Oh, we have one over here. Here, I'll bring it over.
Hi, this is more of a comment, I guess, than a question. But at Harborview Medical Center in Seattle, the psychologists experimented with Southeast Asian refugees who'd been through the Vietnam War and the Khmer Rouge genocide. And they found that rather than coming in to talk to the psychologists in an artificial situation that wasn't necessarily culturally appropriate, that getting people together for community food preparation and talking about their experiences in a community context where they were doing activities that reinforced the normalcy and the safety of how far away they were from the situation, they found some really promising results. They did not formally study it to my knowledge, but it seems kind of to reinforce what you're talking about, I think.
Yeah, that's really interesting to know. Yeah, that's great. Thank you.
Are there any others? One over here.
That was a great talk. Thank you very much. I wanted to know if you had any thoughts about I guess now I can hear it. Do you have any thoughts about the interplay between the value of validating a patient and their expectations about pain versus the possibility of them feeling diminished or invalidated when you try to send these signals to decrease their perception of pain?
So you mean when you kind of when you send signals about other people's? Yeah, I mean, in the practice, that's probably a fine line because you kind of want to definitely validate the subjective experience of the person, and I think these kind of social expectations or social influences should kind of only be used to kind of create hope or positive expectations, but not like devalue or devalidate subjective experience, definitely.
Leonie, I have a really quick question. how do you know that this manipulation of the prior ratings is a social manipulation and not just a cognitive manipulation, right?
Yeah.
You can get the same results if you tell people simply, we're going to give you a mild stimulus versus we're going to give you a severe stimulus. Maybe, does the fact that the ratings came from other people, quote unquote, matter for sure? And what would happen if you had real people?
Yeah, that's a really good point. So we don't know, I mean, I think a lot of that is just kind of a change in expectations. I think that social information or telling people that these are other people's pain rating is one of the best ways, or it seems a very robust way to create these expectations. And we're kind of planning follow-up studies to look at like in versus out group effects, for instance. And then we also plan to study effects of oxytocin on these social effects to kind of see whether there's some modulation, yeah, or also based on trusts and, yeah.
Cool. Thank you very much. We're going to move on. Oh, do we have? Oh, I'm sorry. Okay. Sure.
My question was, we've talked a bit in the summit already about just cultural beliefs and how that influences people's pains and just our cultural notions of what pain is. And how do we go about, or I mean, this is a kind of a big question, but shifting those cultural beliefs, showing how you can have a positive impact too? Is there work being done to kind of look into how within a culture or community those beliefs can shift?
I'm not sure there's kind of research on that. I think, I mean, there's definitely some kind of, yeah, I think there's no systematic research on it, but I think that definitely over time these kind of things shift. What comes to my mind is kind of beliefs about childbirth that were kind of very negative in the 50s and 60s. And I mean, still in most Western societies, childbirth is kind of associated with anticipation of a lot of pain. And kind of in some areas, this kind of begins to shift based on kind of more education and kind of approaches. So I think, yeah, there's definitely shifts and it's continuous in motion, I think. Okay, thank you.
Alrighty, next up we have Dr. Christopher Moyer, who is a former college professor and massage therapy researcher. He's the co-editor and author of numerous chapters in massage therapy, integrating research and practice, and he'll be presenting research examining likely parallels between massage therapy and psychotherapy, with an emphasis on the possibility that the therapeutic bond may be important in producing beneficial outcomes in response to massage therapy. So, Chris.
So as I'm taking a moment to switch the slides over here, I will just mention that we just heard a piece of, wow, that's disorienting. Okay, I'm not seeing what you're seeing. I'll just point out that Dr. Koban was talking about a piece of laboratory research. She was talking about a piece of laboratory research. I'll be talking about a piece of clinical research where we're kind of splitting the difference between what goes on in the real world and having some control over the situation so that we can study it. Thank you. I think it may be open in more than one place, maybe?
It is, yes. Good call.
Thank you. Okay, looks like we're set. Almost set. Okay, I think I have it. Okay, so I'm going to begin, I guess I've already begun, but I'm going to begin again by telling you a little bit about what my thinking was around the years 2004, 2005. And in 2004, I, along with some of my professors, had just published a meta-analysis examining the entire literature on massage therapy as it relates to anything psychological and also some things physiological. And we found a pattern of results that I think was very interesting. We found that there were some very strong effects for depression and for anxiety, especially if a person received a series of massage therapy treatments. They tended to have very impressive reductions of anxiety or depression compared to controls. And this went along with some thinking I'd already been developing going into doing that research, that there were probably some important parallels between massage therapy, which had not been researched very much up to that point, and psychotherapy, which has been researched extensively. There's many hundreds of studies looking at process and outcomes in psychotherapy. Also at this time, other researchers who were looking at massage therapy, and again, this was a fairly small field and still is fairly small, were conceptualizing massage therapy entirely as a physiological treatment and phenomenon. And in fact, even now, a dozen years later, other researchers, as best I've seen, are still treating it almost entirely as a physiological treatment. There seems to be very little consideration in the research for the psychosocial context and interactions and how they might influence both the process and the outcomes of this form of treatment. So I was thinking about whether the psychosocial context of this treatment mattered, and I was thinking about this more than ever when we finished this meta-analysis that showed this pattern of results. I failed to mention when I was reviewing those results, not only did this meta-analysis show very strong effects for depression and for trait anxiety, but it invalidated the former claim that massage therapy was having a strong effect on stress hormones. So if you read research written by others, such as Dr. Field from University of Miami, her research places a strong emphasis on the theory that massage therapy reduces cortisol, stress hormone produced by the adrenal gland. The problem with that theory is the data don't support that theory. In fact, the data refute that theory. And this data has been now out in the literature for a long time, and the pattern is very clear that effect is not there. And yet they persist with that. Isn't that the line right now? Actually, she persisted. But this is not in a positive way. This is persisting against the evidence, so not good. So I was wondering about two things in particular. One thing I was wondering, does therapeutic bond matter in this form of treatment? In the psychotherapy literature, this concept, and it's conceptualized in a variety of ways, but this general idea that the therapeutic relationship between the provider and the recipient might be a very important part of how the treatment works. I was also wondering if it's possible that these studies that we'd reviewed, if spontaneous psychotherapy might be taking place in them. What do I mean by that? Well, there were a few dozen studies looking at massage therapy for anxiety, for depression, and there was literally no, I want to emphasize, no accounting for whether the treatment providers and the patients or recipients had spoken before, during, after, how much, what about. So it's possible, at least in some cases, if not in all cases, that maybe these folks started conversing and that the conversation was essentially psychotherapy. And so it's possible that some or all of these effects might have been from a mechanism that no one was even considering. So this was on my mind. And with these ideas, and on the heels of having published a really good paper, we obtained a grant from the Massage Therapy Foundation to do a clinical study to examine those things. Now, I'm not going to be talking about pain directly. I'll come right out and say I don't know as much about pain as the pain experts I'm sharing the stage with. My main interest is in things like anxiety and depression. There are one or two people in this audience who will tell you I don't know anything about pain, but that's another matter. I know a little bit. So I'm going to be talking about psychological distress. Needed to catch my breath. I think, and I was thinking about this, and I was thinking, you know what Rajam should do? Is she should have the San Diego Pain Summit in the spring, and she should have the San Diego Psychological Distress Summit in the fall. And then, okay. I thought that was fun. So we were looking at pain exactly, but as Dr. Koban pointed out, and as lots of scientific literature shows, there's a link between certainly anxiety and pain, and anxiety is a component of psychological distress that we're looking at here. So our outcome measure in the study that I'm going to detail for you was the brief symptom inventory, and this is used in hundreds of studies to measure the kind of distress that one might want to measure in a psychotherapy research study. And so it asks a person, during the past 7 days, how much were you distressed by? And then there's stems such as nervousness or shakiness inside, feeling blue, nausea or upset stomach. And there's 53 of these covering a range of ways in which a person might experience distress. So I won't be talking about pain as the outcome in this case, but I still think that we've got plenty of relevance for pain and pain treatment here. And to further make that point, I'm not going to try to read everything here, but I collected a variety of ways here in which anxiety and pain are linked. All of these assertions on the slide come from the reference listed at the bottom from their review section, an informative paper entitled Exacerbation of Pain by Anxiety is Associated with Activity in a Hippocampal Network. And they show in several ways the ways in which anxiety and pain can be linked and how we might think about that. So I'm going to move past that quickly and assume everyone is going to accept that there's likely a link there. So we got the funding for this study, and I was very lucky being at University of Illinois that we had in the same town an outstanding massage therapy clinic headed up by now my friend Doug Nelson. So Bodywork Associates of Champaign, Illinois agreed to work with us. They did this in the interest of science. They didn't stand to profit from this. They showed a lot of trust in letting a graduate student come into their offices and wire it up with recorders, and they were really just terrific. Doug is a terrific guy, and all the people in his staff were wonderful. And he allotted 6 of his most experienced massage therapists to work with me on the study. And these 6 therapists would always work with the same person, so our subjects had continuity throughout the study, and they came in for 5 one-hour sessions of what was described as Swedish relaxation massage. Now, don't throw tomatoes at me for using those terms. There are people who are going to lose their minds if I say that. But essentially the kind of standard massage you might receive if you came in and asked for a Swedish massage. Which is to say not very much standardization. And in fact, we didn't standardize it all that much in that we even allowed for there to be customization. In clinical research, there's always this decision to be made, and there's no good way to make it really between how tightly should we standardize the treatment and how flexible should we allow it to be, and there's arguments for anywhere along the continuum. The only way to solve that problem is to do a bunch of studies all along the continuum. Well, we were doing one study. And so the measures, as I mentioned, and I'm going to show you a diagram of how all this works in a moment, were the brief symptom inventory, which I already mentioned. To get into the study, you had to be interviewed with a structured clinical interview. I conducted this. This is a rigorous interview that takes about 2 to 2.5 hours, and at the end of it, if it's done correctly, we have an accurate diagnostic and statistical manual diagnosis for you. So we wanted to ensure that the people coming in were a good match for the study in that they had anxiety or depressive disorders and that they didn't have other disorders that would not be well suited to what we were doing. The attitudes toward massage scale is not important to what I'm going to be talking about today. We used a slightly modified version of the therapeutic bond scale. This is an instrument that is used in psychotherapy research to assess the bond that develops between a patient and a psychotherapist. And it says here we used a reduced version. All that means is there were a couple of questions in it that made no sense for massage therapy. They were questions specifically about the type and style of psychotherapy. So we just took those out. And there weren't very many of those. And so we were still left with a very complete scale that we had reason to believe would be valid for what we were doing. And I have a sample of it with me if anyone has questions about it. We also made audio recordings of every massage therapy session, and this is because we manipulated, without the subjects knowing it, we manipulated the study so that there would be two groups. There would be some people who were assigned to a talk permissive condition, and the therapist would be alerted to this by a little color-coded sticker or something that the patients would not know about. And in talk permissive, the therapist was instructed to talk as much as the patient wanted to talk. They weren't encouraged to keep it going, but it was under the control of the patient, and they didn't discourage it. In the talk restrictive condition, the therapists, again, the same therapists, restricted conversation. So there might be a little conversation at the beginning of the session, but if the patient or the recipient showed a tendency to want to keep on talking, the therapist would gently and empathically suggest that, well, massage is probably going to be better with less talking, or, they were discouraged from talking. And so we recorded all of these. So at the end, we had 180 hours of audio recordings that we had to, that students that I recruited had to type up. That was great. And then we did exit interviews. Okay, so this concept of therapeutic bond, here roughly is how it's defined by the folks who created the therapeutic bond scale. The therapeutic bond extends beyond patient and therapist roles to include certain personal qualities of the relationship that forms or fails to form between the participants. And they theorized that there were three dimensions to this: working alliance, an investment of the self into the appropriate role by each participant; empathic resonance, the patient's and the therapist's sense of understanding and being understood; and mutual affirmation, an interest and endorsement of the other's well-being. So these are the kind of things that they've designed the instrument to try to measure. Briefly, I think in the massage therapy setting, the latter two are probably much more important than the first one, but that's just a conjecture. Okay, so we placed this ad in local newspapers, and we also had it read on local radio and such, recruiting people who were distressed or anxious or depressed to contact us for an experimental non-drug treatment for those conditions. And then there was my lab phone number there, and I would come in each day, and I would have messages from strangers in the community who called me because they were distressed, which I don't really mean to make a joke about that. I mean, I realize I just said that kind of humorously. I don't mean to, it's not really humorous. I guess the reason I highlighted it that way is even now I think back to what an interesting situation that is, to put that ad in there and be like, if you're distressed, call my office and I will call you back. And it was a really interesting, there were many interesting situations that I encountered. Okay, so this may be a little harder to see than I would like it to be, but I'm going to describe what you see here. This is the study protocol. So starting up in the upper left-hand corner, there again is a picture of that ad. Somebody responds to the advertisement, and when they call, I administer the brief symptom inventory to them on the phone, or I call them back. And if they met a certain threshold that suggested that they really were clinically distressed, they were then invited to come in for an interview. If they didn't meet that threshold, they were excluded. And of course, we gave them referral information, of course, to everyone who might want it. But if they were included, you go further down the line, and they came in, and we administered the brief symptom inventory again, and we also did, it says SCID IP, that's the structured clinical interview. And depending on the results of that, they were either included or excluded into the study. Some reasons they might have been excluded, the main ones were if they had a condition that was not suitable. So if they, in addition to having an anxiety disorder, if they also had an active eating disorder, if they had symptoms of psychosis, I'm trying to think of There was one gentleman I interviewed who scared me into how much he was interested in fire. We referred anything like that that didn't seem appropriate for our study they were given referral information. So after this, if they were included, they were randomly assigned to one of those talk restrictive conditions. So we're about just left of center here. And then they received 5 approximately weekly sessions of massage therapy. And at each session, they completed the brief symptom inventory again. So they've now completed it at the end of this 7 times. And then there was approximately a 1-month follow-up interval where they completed the brief symptom inventory 2 more times, somewhere in the middle and at the end. And at the end, there was also a follow-up interview. So there really was a lot of data collected from these folks across this time period. Okay, so we talked to over 100 people, and we ended up with 31 people who were enrolled. 27 of them did all 5 sessions, 3 did 4 sessions, which we considered complete for our purposes, and 1 person dropped out. And the thing I want to emphasize here, a little bit more about the participants, 20 of these people had a current anxiety disorder of the 30, 20 had a current depressive disorder of the 30, and 10 of those 30 had at least one of each of those. And their global score on the brief symptom inventory was 1.61. Scores on this scale range from 0 to 4. 4 would be you endorsed every item to the maximum. You don't see that. The important thing here is these people were quite distressed. This was a true clinical sample representative of what you might see of people in outpatient and possibly even in some cases inpatient psychiatric treatment. One of the first things we'd have to ask ourselves before looking at the results is if our experimental manipulation worked. So we divided people into these 2 groups, this talk permissive and talk restrictive, because we wanted to test the possibility that maybe massage therapy was producing these dramatic antidepressant and anti-anxiety effects through spontaneous psychotherapy. The manipulation definitely worked. On average, people in the talk restrictive condition spoke 640 words in a session. That was mostly at the beginning and at the end. People in the talk permissive condition talked almost continually. And we looked at all of those recordings, and I didn't really have a systematic way to do this. I'm just going based on experience. These conversations were not psychotherapy. I didn't see a single instance where something that looked like, a helpful interaction about reframing depression or something like that took place. They were very day-to-day kind of conversations about the grandchildren and my car broke and that sort of thing, which doesn't mean they couldn't have been therapeutic, but they didn't look anything like my knowledge of how psychotherapy unfolds. And I've done psychotherapy. In case that's not clear, that's not just me guessing. So clearly this manipulation worked. Now, since we're looking at 2 independent variables, we have to consider the fact that those interacted with each other. So we could ask the question before we look at the outcomes, did these 2 conditions, talk restrictive and talk permissive conditions, result in different levels of therapeutic bond? Well, in the statistical sense, they did not. The scores were close enough together that when you run a statistical test on them, they're not statistically different. Now, having said that, we've got very small groups, so the power to test for a difference is pretty limited here. So we can say that they didn't differ, but I don't think we can say that with a high degree of confidence. What we can say is that a reasonable level of therapeutic bond developed in each of those groups on average, and that the values are in the ballpark that you would expect to see in a psychotherapy study. How am I doing on time, Jason?
Yeah, a few more minutes.
Okay. Okay, so we used a statistical technique called growth curve modeling to examine these results, and I'm not going to get bogged down in exactly how growth curve modeling works. It's complicated. You can look it up later. There's probably a great Wikipedia file on it. Here is the results averaged for all 30 participants, regardless of group or therapeutic bond. So you've got a 1-week interval at the beginning there where there's no change taking place. Now, if I plotted all 30 things up here, you would see some change, but it's random. It's not going in any particular direction. So when you average it, people in that first week, from the time they call my lab till they come in and I interview them and they're admitted into the study, they're not changing. And they're at as I mentioned before, they're at this level of about 1.5 points on the brief symptom inventory. The dotted line you'll see at the bottom, this is the level that would be associated with clinical significance. And very briefly, clinical significance, defined in psychology, is the point at which, if you were below this score, you're more likely to be part of the healthy population than, the disordered population. There's a little more to it than that, but that's the very short version of it. So if we saw results dipping below that line, we would be very happy, and we would think we have a very effective treatment here. So you can see on average, that first week, nothing's changing, and then you see the line go down pretty dramatically, and that represents the change on average that's taking place as these people are getting their 5 sessions of massage therapy across about 5 weeks. And then we follow them for about a month after that, and they start to regress a little bit. But by the end of that month, with no treatment, they're doing much better than they did when they came into the study. So on average, we've got a very nice-looking effect here. It looks like massage therapy benefited these folks quite a lot in terms of psychological distress. So now we ask ourselves, what about the experimental manipulation? Did the talk-restrictive and talk-permissive groups do differently? It turns out that they did. And did so in such a way that the talk-restrictive group did considerably better. In fact, if you do a statistical test, there's a statistically significant difference here, even with these very small groups. So if you were talking with your massage therapist spontaneously, you did not as well in massage therapy on average as you did if talk was restricted. This seems obvious in hindsight, but sometimes things seem obvious in hindsight with science. We had to eliminate this possibility that spontaneous psychotherapy was taking place, and to my mind, we definitely eliminated that likelihood, both because the content of the conversations did not seem therapeutic, and the results seemed definitively better when talk is minimized. Okay, forgetting the talk conditions now for a second, what if we look just at that therapeutic bond as a predictor? And I've only got a little bit of time left. So we can also look at the results independent of the talk and just according to how much therapeutic bond the recipient reported. And here we've got, I think, what we would expect, but an encouraging, significant difference. People who reported a higher level of bond, and this is not by group here, that's a continuous variable. So what we've got charted here is we've got one standard deviation above and one standard deviation below the average. So that high bond line is charted. If you reported having a standard deviation better therapeutic bond than the average person in the study, you had a more dramatic increase, and in fact even dipped below that level for clinical significance. So it does seem that possibly therapeutic bond is an important driver of outcomes here. And I do have one other slide which shows the mixed effect of both of those things, and it's actually my last slide, and I kind of don't want to show it, because in hindsight, there's too many variables in this study. It's a little too complicated, and there weren't that many subjects, but I know you want to see it, so I'll show it anyway, and then I'll be ready to take any questions before the final presentation. So it's interesting and encouraging, but even after all this time, I'm not exactly sure what to make of it. And in hindsight, I would do some things a little bit differently. I think the most interesting story that can be told here, and there are several, is that the trajectory that we're plotting here for talk restrictive and high therapeutic bond, that is, you had a very strong therapeutic bond with your therapist in the absence of chit-chat, is the line on the bottom. And it shows the strongest effect, and it also shows the greatest retain those improvements the best in the follow-up period, whereas the other three sort of manufactured groups in those two variables, they all end up in the same place at the end of the follow-up period. So in hindsight, I would do this a little differently. I might have done this in 2 or 3 studies, and I can say more about that if it comes up in the questions, why that's the case. But I feel like we did uncover some things, particularly the fact that we found some pattern for therapeutic bond, I think in some ways is the most interesting finding, along with the fact that under good conditions, we were able to see symptom reductions that were very strong and very clinically significant. And there we have it. Go ahead.
Answer questions.
That was fascinating. Do we have questions?
Yes, thank you very much. So I'm a PT, and my question, would you consider the ones who they had restricted conversation had more awareness and had more mindfulness during the massage therapy, which I think contributes to everything. We know that when you're mindful during any kind of treatment, you have better outcomes. Even for acupuncture, if you're mindful of it versus when you're distracted, you have better outcomes.
First, I need to make sure that this other microphone, am I coming through this other microphone? No. I turned it on. I'll use this. Thank you for your question. I think you're exactly right, and that makes sense. And it goes with, a lot of things practitioners have voiced to me in presenting this. And not only the recipients, not only might the recipients be more attentive to what's going on in their body and more mindful as they're receiving the treatment, but also the therapists have the opportunity to be more mindful, less distracted. I think that's likely exactly right. Nevertheless, we also know, not to take anything away from your question and the way you're framing it, we also know that if you put 2 people in a private place to talk about things that matter to them, in the form of psychotherapy, that also leads to improvements if it's a mindful conversation. So even though we didn't find that talk permissive condition was optimal, we did, I think, address the question of whether it was likely that was happening spontaneously in massage therapy research. So I think I agree with you exactly. I think that restricting the talk is optimal for this form of treatment and related forms of treatment, probably like physical therapy, if it's managed correctly.
Thank you for the talk. That was fascinating. I was wondering if there was any opportunity to look at those that it was in the talk restrictive group, the effect of wanting to talk but being restricted versus spontaneous ability to talk if you want or not talk if you want.
Right. So you're introducing the possibility that there are, patient preferences and differences, and I agree with you that that's likely the case. We didn't look at that in this study, and also I think even if we'd, thought about looking at it, we probably didn't have sufficient subjects to do a meaningful examination of that. But I think in theory, you're right that people would vary in that. We did take care to make sure no one was being told they couldn't talk, right? It wasn't like, instruct the patients they're not to talk or something like that. It was if they're chattering, gently encourage them to do less of it. And I can tell you that there were no cases where the therapists had to really do much to make that happen. It just kind of happened implicitly. Which I think is interesting and instructive. It doesn't take a lot of message from the therapist to guide the recipient on that behavior. So it's a subtle manipulation that has, in every case we saw, the desired effect.
Okay, we'll take one more before moving on.
Hi, this study that you've just done here is kind of replicated in my clinic.
Oh.
So I have a profoundly deaf therapist as well as four others that obviously speak during sessions. And so that is what we find is that high bond with her clients that come through. She's booked out every single week. And that's not to say that others are like that, but they don't get that same effect that they do with the others. And this is great to go back to her and show her this, because this is something that she feels she misses out on.
Oh,
and I keep
interesting.
emphasising to her that actually this is an advantage that we all wish we had to some degree. So this is great.
I can believe that, and I can relate one other anecdote. I first got interested in massage therapy through my involvement in the sport of cycling, which has a long history of using massage therapy. And one of the most famous cyclists of all time, Fausto Coppi, an Italian rider, he had a massage therapist and assistant named Cavana who worked with him almost exclusively, and Cavana was blind. And, they all believed that, his hands could see better than a sighted person. And, I don't know whether there's anything to that, but it's an interesting parallel to what you just related. So maybe. Thank you.
Great. All righty, and our last speaker is Beth Darnall, who's a clinical associate professor in the Department of Anesthesiology and Perioperative and Pain Medicine at Stanford. She's a pain psychologist and scientist. Her NIH-funded work focuses on pain catastrophizing mechanisms and treatments. She is currently the co-chair of the Pain Psychology Task Force of the American Academy of Pain Medicine, and she is the author of a number of books, one called Less Pain, Fewer Pills, Avoid the Dangers of Prescription Opioids and Gain Control Over Chronic Pain in 2014. And her latest book is the Opioid-Free Pain Relief Kit, 10 Simple Steps to Ease Your Pain in 2016. So, Beth?
I'm going to see if I can use this. Is it possible to turn this mic off so it doesn't do that screechy? There. Okay, great, thanks. Okay, thank you. Thank you, Jeff. Thank you, Chris. And thank you to the organizers for inviting me, and to all of you for your time and your attention. These are my disclosures, where my funding comes from. This Axial company is focusing on helping physicians reduce opioid prescriptions and treating pain differently. And so I don't need to tell all of you that there's a crisis of pain in the United States. This is described really well in the 2011 Institute of Medicine report on relieving pain in America. And what those data showed was that roughly 1 in 3 Americans has ongoing pain of some type, and that this is impacting them in a meaningful way. And this is a huge impact on our society economically as well. This number, $635 billion, includes medical treatments and also lost productivity from work. And of course, I think we all understand the amount of suffering that pain confers. So the National Pain Strategy came forward in 2016, and this was really the response to the IOM report. The IOM report described this massive problem of pain in the United States, and the National Pain Strategy was more the sort of the practical roadmap. What are we going to do about this? How are we going to do this differently as a nation? And both the IOM report and the National Pain Strategy brought forward this concept that we need to rely less on medications, and we need to help people gain some of the strategies to help themselves. And so because I'm a pain psychologist and I'm here to talk to you about pain psychology, I'm just going to emphasize the psychological pieces and their emphasis on psychological treatment and self-management, but that's not at the exclusion of physical therapy, certainly. So psychology and pain are integrally linked. I'm going to spend my little bit of time really unpacking that. And a lot of the other speakers at this conference, it seems like it's really interwoven into every single talk, and I love that because it's a part of everything. It's a part of everything we do. Psychological disorders and pain. What we see is that people who have a psychological disorder, a mental health condition, are much more likely to acquire chronic pain and to also have pain, to experience that pain at a greater intensity. And so this is really well established in the data. I'm just giving a few examples. And so clearly they co-occur, but we can see that there's this, that one will precede the other. There's various studies showing this, relationship between the two. And then we also see it in the other direction, where we see that individuals who have pain are much more likely to acquire a mental health condition. And so while there's this co-occurrence, we can also talk about it as being a bidirectional relationship between the two. But in fact, I like to talk about it more in that there's these shared mechanisms, and there's just a tremendous overlap between the mechanisms of pain and the mechanisms of a mental health condition or a negative mental experience, maybe a better way to even talk about it. And so one of these, just to sort of unpack this a little bit, one of the, to me, more interesting mechanisms, shared mechanisms between pain and mental health disorder is the immune system. And so we know that people who have depression, for instance, have elevated pro-inflammatory cytokines. We can measure this in the blood. And we also see this with people with chronic pain, and this is across varied chronic pain conditions, that we can detect these anomalies in circulating cytokines in the blood. And then also what we see is that when we experience psychological distress, psychological stress of any kind, if I were to leave here now and walk across the street and a car almost clips me and I have a stress response, that will be met with a subsequent increase in pro-inflammatory cytokines over the next couple of hours. And so we see this relationship between psychological disorders, chronic pain, and also stress. And this is some of my work had been focusing on actually pain catastrophizing as being a stressful experience and trying to quantify whether or not catastrophizing would elicit a pro-inflammatory cytokine response. And some of our pilot work suggested that it did, but only in women, interestingly. And I could talk about that later if you'd like to. Other mechanisms, this shared overlap between mental health disorder and chronic pain is obviously neural mechanisms and what we see in terms of brain function and also in the structure of the brain. And this particular study, which was led by colleagues at Stanford, were looking at comparing individuals who are pain-free, so healthy individuals, to the brains of individuals who have chronic pain, and showing that the brains of people with chronic pain are different than people who don't have pain. And in this particular project, we're showing that people who have chronic pain display this overcoupling of connectivity between the central executive network and the amygdala, so some of the emotional regions of the brain, and that effect was really driven by rumination. And what we used to measure rumination was a pain catastrophizing scale. So rumination is one component of the pain catastrophizing scale. It's also one component of depression. And so it's when we go over and over and over again something in our minds, certainly. And if you think about it, we're training neural networks over and over and over. And so it's no surprise that you see this connectivity, these relationships in a very clear way. Now, the definition of pain, I'm sure this has already been presented to you, but I'm going to present it anyway because I always do in every single talk. This is from the International Association for the Study of Pain. And as they define it, this is a stricated version of it. I kind of clip it down to get it on one slide and really focus on what I believe is important here, is that pain just isn't that noxious sensory experience that we feel when we place our hand on a hot stove. It's also an emotional experience. And you've heard some of the other speakers talk about that today, that pain is also an emotional experience. But what I want you to observe here is that psychology is actually baked into the definition of pain. And this definition was put forward in the 1970s. So this has been recognized for a very long time, and this is very important. This is something that I highlight with all of my patients, and I recommend that you do too. Now, pain is very complex, right? All of these different psychological factors go into our experience of pain. So I started this talk and I was talking about, mental health disorders and anxiety and depression and post-traumatic stress disorder and all of these things, but we don't need to have these mental health disorders to have our psychology negatively influence pain or positively influence our pain. So where I really like to focus most of my time is just on all of these factors in our lives and, as humans, all of these different aspects of what's happening and how we're interpreting things and what we can learn from that and how we can use that information to our advantage so that we can suffer less. So expectations, you heard this earlier, that expectations have a profound influence on what we feel. And in fact, what we expect to happen, if we have positive expectations, that can be analgesic, and that's really the foundation for the placebo effect. And if we have negative expectations for pain, that leads to an amplification of pain, and that's really what at the core of pain catastrophizing, and it's also the nocebo effect. So I like to describe catastrophizing as being, essentially a nocebo effect. So all of this, our expectations and our context and the meaning we give pain, the interpretation, what we're feeling, all of this goes into what we see in the real world, where you can have two individuals who experience the exact same injury, and one person, their pain isn't that bad, and they go on, they heal, they get better, and it's no problem, and the other person could become profoundly debilitated from that injury. And why is that the case? Well, again, all of these individual factors, there's also genetic factors and actually, sex factors. You'll hear some of that tomorrow probably with Jeff. But what I'd like to just highlight and emphasize is these individual factors in psychosocial functioning that have a profound influence on the trajectory of pain. So as clinicians and even as patients, because we're all patients too, we tend to focus a lot on the localized site of the pain, and that's truly appropriate. But I always like to bring people's attention to the fact that pain is fundamentally a product of the nervous system, and that if we focus too much on the localized site, then there's a missed opportunity to help people focus differently in a more positive way. And why I say positive is because that's something that they can engage in. I explain to my patients that pain is their harm alarm, and it's designed to get their attention, and it does it really well. And it's there to protect them. It's there to protect all of us. It's designed to get our attention so that we can escape whatever the threat might be, whatever might potentially be harming us. And we're born knowing how to escape pain very, very exquisitely. We're motivated to escape it, and we typically know how to do that. But not in the case of chronic pain. We can't escape something that's happening inside of us. And so that's very confusing to people naturally. And while we're born with the motivation to escape pain, we're not born with the understanding about how to modulate it, how to modulate the distress that it causes. And these are simply learned skills. This is just information and skills that can be learned. And this is so critical, and it's so helpful. And one of the reasons why it's so important to focus on this piece is because if we don't, people go down the pathway of over-medicalization and taking opioids and other medications. And all treatments and medications may have their place, but what if we start with the skills and the information first and optimize people and their ability to really turn down the dial in their own nervous system? So the pain catastrophizing, this is the land where I dwell, sort of scientifically and clinically. Does everyone in the room know what pain catastrophizing is? Pretty much, yeah, I'm getting like a lot of nods. Okay, so rumination, helplessness, and magnification. And you see this in the people that you work with. We tend to measure this with the pain catastrophizing scale. It's just these 13 little questions. These 13 little questions. Pain catastrophizing scale is interesting. If you don't even have pain, you can take the PCS because it's not written for people with chronic pain. The directions ask, think back to a time time when you've had pain, like if you saw the dentist or had an injury and you experienced pain, how do you tend to think and feel in the context of pain? And the reason why I'm emphasizing this is because these 13 questions, you all can take them in this room, and your score will predict whether you go on and develop chronic pain later in life. And I'll say more about that in a moment. But people rate the frequency at which they experience these thoughts and emotions in the context of pain. And these 13 questions are very powerful prognostic indicators for the trajectory of a person's pain. In fact, we see pain catastrophizing is associated with an array of negative outcomes, unsurprisingly increased pain, but it's associated with pain-related disability. It mediates the efficacy of pain treatments, so pain treatments don't work as well for people who are high on catastrophizing. It predicts the development of chronic pain. I was just mentioning a population-level study with thousands of individuals that give people the PCS at a pain-free baseline. And then they follow up with them 1 year later. Who goes on to develop back pain? People who are higher on the PCS. So how is this the case? How is it that these 13 little questions can measure something that is so profoundly impactful and important? What are the mechanisms behind catastrophizing? This has been something that I've been intensely interested in. And what we see is that there are some let me just preface this by saying there are a lot of different mechanisms here. And we could talk about the behavioral mechanisms. And, if someone's catastrophizing, they're less likely, there's fear avoidance behavior. They're less likely to do their PT or to do other things. All of that is true. But I'm just going to focus on a couple of others where there's even more science behind them at this point. And what the science tells us is that there's very clear neural mechanisms behind catastrophizing and its impact. And so we can put people in the scanner while they're experiencing pain, and we can see how the brain operates under the influence of catastrophizing, so a person's own psychological distress, and we see alterations in brain functioning. And what we see is that when people catastrophize, they literally light up regions of the brain associated with the experience of pain. So the way I describe it to my patients is you're basically lighting up pain in your brain when you're catastrophizing. It's an amplification of pain. And it doesn't just happen in the moment while they're catastrophizing in the scanner. If people are catastrophizing on a regular basis, it actually changes the way the brain is functioning at rest. And so that's called the default mode network. When you're essentially sort of tuning out, zoning out, hanging out, your brain will be functioning differently because you have trained those pathways so exquisitely. And then we also see that people who catastrophize have different structure of their brain as well. And all of this basically primes the nervous system for more pain. So if you're really worried about something and fearing it, you're going to get it. It's kind of like reeling it in on a fishing line. But unwittingly, nobody wants more pain. They just don't know what to do about it. Okay, and so this particular study I thought was really cool, showed, altered attention. Basically, when we're anticipating pain, we have heightened emotional responses. We see this cascade of catastrophizing, and we can describe it neurally. This is a really interesting study conducted in migraineurs that showed that there's altered brain structure and function in migraine that's associated with the severity, the duration of the disease, but also they found that this overlay of catastrophizing, that these changes that they saw in the migraine brain in terms of structure and function were greatly amplified, and that was entirely predicted by catastrophizing. So the way I explain it to my patients is I say, imagine that this is, your pain, and you know it well. That I only work with people with chronic pain. So they're living with their pain on an ongoing basis. And I say, and this is what happens when you catastrophize. It's like picking up a can of gasoline and pouring it on that fire. Not because you want more pain, it's because you don't know what to do differently. And so I tell them, I ask them, I say, now, if I teach you how to stop catastrophizing, is that going to cure your chronic pain condition? And the answer is no, and you all knew that, right? But I ask anyway, I say, no, it's not going to cure your chronic pain. I can't cure your chronic pain, but I can help you get back to this, where you're not unwittingly amplifying your pain. And I can help you gain a level of control over your pain, which is so incredibly critical. So how do we do this? Well, what's interesting about catastrophizing is that the literature shows that it can be effectively treated in a lot of different ways. Like, there's studies showing that yoga treats catastrophizing. I think I saw something about PT too, like, and maybe if it's done with the cognitive stuff too. So there's, and meditation will reduce catastrophizing. I'm just going to talk about cognitive behavioral therapy because it happens to be my wheelhouse, but I never want to come forward and pretend like, I'm the only game in town or psychology is the only game in town, because there's a lot of ways to come at this. This is just one way. But historically, there's 25, 30 years of science behind cognitive behavioral therapy, and about 20 years behind its ability to reduce catastrophizing. 8 sessions, talk therapy conducted either individually or with groups of patients, where they learn the right information. They learn a lot of what I just told you right now, just putting the pieces together, and then it's like, okay, well, what do I need to do differently? And you teach them some core skills like the thought reframing, restructuring, relaxation response. How do I calm myself when I'm so distressed and worried? How do I change the channel in my brain? So that's how we treat catastrophizing, and that's how we treat a lot of other factors when it comes to chronic pain. And I gave all of this scary data in the beginning where I'm like, pain changes your brain and catastrophizing makes it worse, and we could all start catastrophizing that, right? But the question is, if we treat it, can we get our brains healthy again? Can we reverse this? And the answer is yes. Actually, this was such a cool study done by David Seminowitz, and this was in 2003. I'm still surprised it didn't get more traction than it did, because I thought it was absolutely amazing. And what they did was they took people, they scanned their brains, they put them through 11 weeks of CBT, and then they scanned their brains again. And what they showed was that, in the beginning, people had atrophy in the areas of the brain associated with pain control. And after 11 weeks, they had strengthened those areas, as evidenced by volumetric increases in gray matter in those regions of the brain associated with pain control. So you literally can train your brain away from pain, and you literally can strengthen your brain. So this is a really great news, and this is the type of stuff our patients need to hear, because they're so demoralized and they're suffering, and they don't even have the normal brain, right? Because they've trained it in the wrong way. So it's really hard for them to see this and understand it and hear it. And so they need continual reinforcement for these messages, which are really evidence-based, really well grounded out in the science. So I became inspired by this one particular study that showed that in as little as 80 minutes, people could learn a skill set where then when they experienced evoked pain, when they were given like a heat pain stimulus, that they had better control over their pain, because what they learned in 80 minutes enabled them to modulate their experience of pain. They were able to reduce pain bothersomeness by like 50%, right? And I thought, that is so cool, 80 minutes, and here we are in CBT, and we're doing like 35 hours. We have people come back 2 hours, like for 8 weeks. I mean, and people can't do that. They have chronic pain, right? They're like, I got kids, I got a job. So my idea was, could we do this differently in psychology? Could we compress things into a single session? That was my goal. I'm like, all right, I got 2 hours with patients. What am I going to tell them in 2 hours to help them? So I created a 2-hour pain psychology class that targets catastrophizing. But literally within that amount of time, I give them the pain education, I teach them the skills, they develop a personalized plan, and they leave knowing what they need to do to put down that can of gasoline so that they can train their brain positively, so that they're no longer unwittingly amplifying their pain. We published this in 2013. Here's just a couple of slides. They learn about pain, what it is, what they can do about it. And this is a key concept. They begin to understand that pain isn't a passive experience, that whether they know it or not, they're participating with their pain. And that's an opportunity to get excited about, because then once you have the right formula, you can begin helping yourself towards better results. Because as I've said before, and I always say this, nobody wants more pain. It's just that people don't have the right formula. And this is a scenario that we see, and we see it all the time with our patients, right? And our job is to help them understand how to understand the science, and then also to give them the roadmap. Because if we don't, then patients go from doctor to doctor, procedure to procedure, pill to pill, and they're trying all of these things, and nothing is working because they don't have that solid foundation under them, which is their brain, which is their nervous system. So in this class, we found that we got really great results. I pulled out my clinical significance slide, and I wish I didn't because Chris was mentioning that. What we found was moderate to highly important changes in catastrophizing from a 2-hour class. We found large effect sizes for this class, and we're very excited about it. Turned it around into an R01 application, and happened to be very lucky. We hit with a $4 million R01 to study this catastrophizing class, and our clinical trial actually launches next month, finally. So, yeah, I know, we need more of that, right? Thank you, thank you. So I just very briefly, do I have like 5 minutes more, a couple more minutes?
About 3 minutes.
3 minutes, okay, so what about surgery? And I feel like this is really important because probably a lot of you see people after surgery, right? And about 1/3 of people after surgery go on, certain types of surgery will go on to have prolonged pain. And what we find is that what distinguishes the people who go on to have post-surgical chronic pain are those with anxiety, depression, PTSD, unsurprisingly, and the big one is catastrophizing. It turns out to be the single biggest predictor of chronic pain. And you might think, well, wouldn't it be the surgeon or the injury type or disease characteristics? No, none of that. It's catastrophizing. And it's associated with greater post-surgical opioid use, length of stay in the hospital. It's associated with delayed recovery after surgery. And the data they didn't really look at this, but I think this delayed recovery is probably because they're avoiding their therapeutic movement and exercises. They're not engaging like they need to. So I did a little lit review, found there's almost nothing on perioperative pain psychology treatments and strategies. Sort of prehabilitation is, you know, what you guys do, but what do we do psychologically? There's almost nothing out there. So I developed what is called My Surgical Success, which is essentially my 2-hour outpatient class, but it's on video so that anybody before surgery could go to this site. They go through the whole class. It's a video class. They download forms, they download the audio, and we just wrapped up a randomized controlled trial testing this video-based, internet-based perioperative pain psychology treatment, comparing it to health education control. Our outcomes are post-operative pain intensity and opioid use, and we're going all the way to opioid and pain cessation so we can construct some survival curves to see whether or not this is helpful. But in my opinion, I think this is sort of the future, is like, how do we best engage patients in their own care? How do we help them get excited about what they can do? How can they learn to bring all of this wonderful scientific knowledge down into their daily lives to help them be hopeful and ideally more functional and less reliant on the pill bottle? And so with that, I will just say thank you.
Thank you. Do we have questions for Beth before we go to a more general discussion? Over here.
Hi, I was just wondering, have you seen, great speech, by the way, thank you for delivering it. Have you seen Adrian Lau's stuff? He did a study recently, he got published with preoperative and postoperative, or preoperative neuroscience education. I just wondered what your thoughts on his article were and his stuff was.
Yeah, absolutely. I mean, I thought it was tremendous as well. And I really feel, I know that there's so many different researchers right now really focusing on this space, and everyone's doing it kind of slightly differently, but it's all beautiful, and I think, it's all converging in the, at the same point. And I'll just say, because you just sort of like raised an opportunity for me to say this, is that, there's all of these different psychological approaches. Well, there's cognitive behavioral therapy, there's acceptance and, commitment therapy, or, maybe we want to do mindfulness-based stress reduction. Within everything, there's these shared mechanisms between what we're doing. And so Adrienne Lau as well, I mean, even just the education piece is so incredibly useful. And then maybe we loop in a couple other pieces, various skills. And I think, the future of precision pain medicine is figuring out which exact strategy is best for which person. Maybe somebody who's depressed would benefit most from something that isn't so sciencey, and they need something else, So we don't exactly know, but it's now with technology, it's getting easier and easier to better phenotype patients on the front end so that we can deliver precision medicine.
Cool. Thank you.
Yeah.
So is the My Surgical class video available to us?
Not quite yet. And I just have to say, this is the worst part of being a researcher, is that you can't just give it away. And it absolutely pains me, because my goal is to just have these on the internet and anybody can access them and download them. I mean, that's the way it needs to be. But unfortunately, we have to publish on it first. So that's what we're waiting for. We got to get our results. But in the future, absolutely.
Hi, I was just wondering, the stuff that you're talking about is basically the psychology aspect, right? So I'm just wondering, when we look at something like graded exposure therapy, not graded exercise, but graded exposure therapy, where they do the cognitive and psychological aspect in that treatment, and then go forward and get the person to obviously confront their exercise, etc., that they're fearful of. So have you seen a difference between, obviously you're not following up and going into the exercise that they're catastrophizing about, is that correct?
Yeah, no, and so me personally, I don't deal with, sort of that piece of following them on the exercise. With my patients, though, for instance, when we go through the treatment and then afterwards, I'm able to see that they're able to become more functional, for instance. But I don't have a study on that one. There are psychologists in the pain clinic at Stanford who actually do, dual treatment, the psychologist and the physical therapist. That's right. And yeah, so they co-treat the patient at the same time. And they do it in classes as well. And I think that's a really powerful way to do it.
Yeah, because I think when I did the literature review on that, is I found that it got better outcomes solely not just having that psychological element in it, and then going into the exercise element as well.
Yeah, I've seen that as well.
Jason, there's something
I'll open this up to all of our panelists. With the different studies that have been talked about, one of the things I'm wondering about is how did the studies that you've done or that you've looked at for the purposes of the presentation, have you looked at whether or not the participants in those studies, if they had particular expectations regarding what type of treatment they would receive or how that treatment would be done, whether it was talking versus non-talking, active versus inactive, et cetera? And how did the outcomes match up with their expectations?
Well, I'll just say I haven't used expectations in my prior work. It is very much integrated into the current very large project that we're conducting now. But I think, my read on the literature is that, it's just really clear that patient expectations are going to influence their outcomes. I mean, it's incredibly powerful. So when I talk about catastrophizing, I say, well, that's like the nocebo effect. They think that their pain's going to get worse, and so how do we help them change that? And I think, you're asking an interesting question, which is, well, what is the patient's expectation for going to a class, that class is going to help them? And the one thing I will say to that is that I address that swiftly right out of the gate by explaining who I am, what my credentials are, that I understand the science, and here's the deal. And so we have to exploit that, all of us, in the clinical realm. And if we don't, we're remiss, because it's really critical to engage the patient in believing that something is going to be helpful. I think going forward, clinical trials need to take even closer look, a closer look at that and to integrate that into the analyses.
Are there other questions people have for the whole panel? Oh, great.
So this question is for Beth, coming from Catherine. If you had to pick one strategy that's the most accessible and most effective for professionals who deliver physical or manual therapists to mitigate catastrophizing, what would that be?
Yeah, it's probably one that you're already using, but I would recommend you apply it very deciduously, and that's the relaxation response. So if you're doing diaphragmatic breathing with your patients, you teach them that, and you really guide them to experience that and understand the difference between when they're stressed and worried and when they're nice and centered and relaxed. Then when they begin to, and I'll predicate this by saying, they have to learn what catastrophizing is so they can identify themselves doing it. So that's critical. That's just bedrock. They have to be able to self-identify, okay, I'm catastrophizing. And then the one skill that you can use with them is, okay, go into your breathing, go into because what you're countering the stress response, but you're also pulling them out of the cognitive spinning because they're going into the diaphragmatic breathing.
This question's for Beth. Thanks, Beth. That was a great presentation. I've used the pain catastrophizing scale in my practice for a long time now, and I've presented on it a lot. And the questions I sometimes get is that term catastrophization is very judgmental.
Yes.
And I don't think it particularly is, because I don't make it that way, but
Yeah.
I'd like you to comment on that.
Oh, listen, if you Google me, I have hate mail from people. There's actually an article that was written about, this word, and I'm like, listen, guys, I didn't coin it. I wish there was a different word too, honestly, because people perceive it very negatively, and there's just a contraction around the word. And I have tried to come up with a better word, and I'm like, I've even thrown it open to patient groups because I was getting like Twitter hate mail, and I'm like, listen, I'd love, if you have a better word, let me know. I'll use it. But that's what we're using. What I do is I introduce it, and then I take care to pull away from it. I don't go over and over again like, oh, you're catastrophizing or whatever. I mean, I just, I basically, what I do after introducing it is I talk about it is your mind-body connection is incredibly powerful, and it's either going to work for you or against you. And we need to help you learn ways to get this working to your advantage so that you'll have less pain. And so then I sort of talk around it using descriptive and positive language, and I avoid that label because the label isn't actually helpful in and of itself. And I think that if we use different words, then people are more open to it, and it makes more sense. They're not going into contraction. They can actually be receptive to the message.
Are there other questions that people have? Please.
Yeah, here we go. I have a question, and it probably relates most to what you were saying, but maybe each of us will have something to say about it. As you were talking about pain catastrophizing and how powerful a predictor it is, and how it's driving chronic pain, I found myself wondering how much the tendency to catastrophize is the personality dimension of neuroticism. And in fact, I'm wondering, is it almost the same thing? Is it really just a proxy for how neurotic a person is? Can you say something about that?
Well, what I can tell you is that one of the things that's really fascinating is if you look at the literature on kids, and kids who have chronic pain and whether or not they catastrophize, and the best predictor of that is whether the parents are catastrophizing. So it's modeled, it's learned. There's probably, a genetic heritability component, but I got to tell you, there has been a study looking at, sort of the genetics and catastrophizing, and it's not overwhelmingly impressive is what I'll say about it. I think that when I see how easy we can sort of modulate this, to me that suggests that there's there's a lot of learning that's taking place. There's a lot of patterning that we can modify that relatively quickly for some people, and then maybe for other people who have deeper issues, maybe highly neurotic or depressed, clinically depressed, they're going to need a higher level of care, certainly. I'm not sure if that answered your question. But
yes, it does.
There were decades of people trying to associate big five personality factors with chronic pain, and it came to very little ultimately, right? That's sort of the genius about catastrophizing. So, Mick Sullivan pulled this concept out of the air that seemed to borrow from different related psychological concepts, but it seems to be the one that has most of the predictive variance. But there are others, right? So I, agree that catastrophizing probably has more evidence than any other psych risk factor, but there are others. I wonder if you would comment on somatization, which is in the OPERA study, which is the biggest study done to date. That was the big predictive factor there. And it's similar, sort of. But
Sort of it is. Sometimes people, will become sort of over-focused on physical sensations in general. I agree. It's interesting. They're definitely related, but certainly less research on it. I'm not sure how much I can comment on it.
No, for sure.
Other than I will say that in this new version of the DSM, they literally, took away what was originally sort of the somatization, and now it's just somatic symptom disorder, which is a much lower threshold to reach that diagnosis. And in fact, if you're just a regular person catastrophizing, you could meet criteria for that, versus the previous, which involved multiple different pain conditions or physical problems, such as a GI condition, some sexual problem, all the way back into childhood, really suggesting a much deeper level of, it's frank psychopathology.
Sure. I have a question for you, Leonie, for everyone really, but I'll start with you to get back to where we started here, which is social factors. Pain occurs in a social context when people live their lives, and we can talk about the therapeutic bond as being a social context, but ultimately they live with their pain with their family and their coworkers and their friends. And I'm just wondering whether anyone can see any sort of therapeutic intervention that relies on the social context that people are living in, or whether this is something that there's not much one can do about. A lot of times when I think of interventions being successful, for example, your intervention, I wonder how much of the effect isn't simply that, these are people that you're getting out of their house, right? And before, they probably hadn't left their house for a while. That's what people do when they're distressed and anxious and depressed. But you're forcing them just to get out, get on the bus, and go to someone who's being nice to them, right?
Yeah, I think there's so much to that. And, from an experimental standpoint, then there's the issue of, do you want that included in your study, or are you trying to partial it out? And depending what you're aiming for. But I'll relate an anecdote that you asking that question just made me remember. One of those 30 people that I admitted into the study was this is a while ago, so I don't remember every detail, but I mean, it was a middle-aged woman, and she was very heavy set, and my lab was up a considerable flight of stairs, and it was a big deal whether she was going to be able to get up there. And of course, I offered to interview her on the bottom floor, but she wanted to come upstairs, as I recall. And her husband brought her, and so I got to see this glimpse of how they supported each other and all. But anyway, getting to what you're saying.
By the way, elevators haven't come to Champaign, Illinois yet?
This was in the Colonel Wolfe School Building, is where my lab was, which was actually terrific. It was almost like I had this entire school building to myself. I was like, anyway, that's a whole other thing. Ask me about it sometime. But, I got this glimpse into what this person's life was like, and how difficult it was just for her to move. The fact that she was coming to the university to do this at all was remarkable, and I think it relates exactly to what you're asking, and it relates to all the other things that were mentioned a few minutes ago that drive what people think about and how they're going to be influenced and whether authority is involved. It's just she's not only getting out of the house, which probably she doesn't do much of, she's moving, which we know is good for her, which you've heard about. She's not merely being treated, but she's coming to this world-class university, and they're going to pay attention to her, and money's going to be spent on her, and it's not just attention, but there's authority, there's science, there's all kinds of stuff that's likely to make the person feel good about being a part of it.
Yeah, I think. So this is basically a kind of placebo effect, what you were describing, right? It's kind of non-specific treatment effects, all these things of being cared for, money being spent on the person, and all these things kind of create expectations, and also, trust and hope in a way. I mean, not only. Kind of one thing I was thinking about regarding the kind of how can we kind of tie this together was the idea that, indeed, maybe especially with children, as you mentioned, that if the parents are very catastrophizing, for instance, maybe we can kind of teach also parents how to interact with children who have chronic pain, who are at risk for developing chronic pain, to kind of develop less social referencing for catastrophizing pain behavior. But I don't know whether there's any.
There's actually one or two fascinating studies, I think Christine Chambers maybe at Dalhousie, about the interaction between the catastrophizing status of the parents and the catastrophizing status of the teenage participants doing cold pressor pain. People are on that. But again, there's very little research in this area, as
and
you
probably
know.
not so much interventions, I assume.
Right, and it's harder to do. Okay, we'll have one more question if we got it. You? Oh, we got some over there? Okay, you go last. We'll do you first.
This is kind of for everybody too, and I'm just thinking about those social influences that you talked about and how kind of it's not necessarily modeled behavior, but thinking that someone rated pain a certain way beforehand, and then also thinking about what Beth was talking about in terms of her classes, the group classes where you're doing the 2-hour class, and you said some are group classes, that idea of using the people who are in the class then as a future mentor to others that can model what that could look like, and if that's explored at all, or what your guys' thoughts are on that kind of thing.
Sort of this idea of peer modeling. It kind of dovetailed on a point that was made, I think, to Leonie and the cultural piece earlier. And the one thing I'll say, I just submitted a large grant application, which I'm very excited to have it done. And one of the aspects of it was including an intervention that is peer delivered. And this is specifically for people with chronic pain who are reducing opioids. And opioid reduction, obviously fraught with a lot of complications and fear and what have you, and that sometimes patients have a hard time trusting. But if they can learn from peers with lived experience, that's the critical piece, learning from peers with lived experience, that they might be more receptive to that. So one of the things that we want to do is better understand understand. But that's not everyone, right? Because some people are like, no, I want to go see the psychologist in the suit, at Stanford, and others are like, I want to go to my church and learn from a peer who's been there. And so that's sort of what we're proposing to study is, the needs of the individual patients, so we can meet them where they are so that they're best able to learn.
Wow. Okay, last question.
So this comes from a little more personal note for Leonie. So I noticed that you're about to be a mother. I'm not sure if that's again or if that's for the first time, but congratulations either way. And
I don't expect to have an answer for this question. I just want to say
But there's a lot of parents raising children that are experiencing varying levels of discomfort for varying reasons. And so, with a child on the way, I'm just wondering, with all of your knowledge, I'm wondering if there are things that you are thinking of that may affect how you choose to, how you may choose to respond to your child as a parent in order to help them.
Okay, that's difficult. I haven't really thought about that much yet. I kind of, usually in general, I kind of try, even when interacting with the children of other people, I usually try, when they fall, I try to not make a big deal out of it and kind of, because I remember some situations where the child, a little toddler, like a 1.5-year-old something, falls down, little scratch on the knee. It's nothing bad, they fall all the time. But then when you kind of look at them with like, oh, what happened? Then they look at you and then there's like this 2-second break and then they start crying when you kind of...
It turns out there's very clear experimental data that that's the right way to do it. The worst thing you can do is reassurance, or you don't make a big deal out of it. That's the right answer. When you do make a big deal out of it, the kid, they see your anxiety and then they internalize it and things are worse.
and it's not just kids either. The emotion research, it's we assume, if we don't think about it, we assume that we figure out our own emotional state by looking inward to see what it is. And we do that, of course, but people lose sight of the fact that and experimental evidence shows that what we actually do is we both look inward and we look outward to see what other people are doing. And that both tells us maybe what we're feeling, and it also gives us a lens for, deciding what's going on within us. And that's a very complicated thing, and I won't, round it out there, but, we look to others to see how we feel.
And of course, that's the very definition of psychosocial, so you've wrapped it up beautifully. Help me thank our panelists. And thanks a lot for coming, everybody.